Good afternoon and welcome to today's webinar, Immunizing for 2+, Enhancing Maternal Protection and Vaccine Uptake, this Tuesday, December 10th, 2024. We are together for the next hour, and as we move on to the next slide, on behalf of the California Department of Public Health, I'd like to welcome all of you. My name is Leslie Amani. It is my pleasure to facilitate today's call, and we are so excited to have you join us today. And we are also so grateful for our partners at ACOG and CIC for supporting today's session. They are here to provide updates for you and, more importantly, your questions that you may have from today's updates. Some of those questions might be answered during updates. However, if not, you can use that Q&A icon to ask your questions. Now, we use the chat feature for links that we're going to drop into the session for you, and links are blue and underlined in the slide deck. But we also drop them in throughout where you have a link to a registration form or a resource or information. And we, of course, welcome your reactions. So if you are ready to get started, by all means, give us a reaction and make sure you've got that chat open because that is where you can find the link to today's slide deck. Great, we've got folks ready to go. And as we move on to our next slide, we want to remind you all we do record these sessions, and we've already got the slides posted. As mentioned, the link is in the chat for you. You can find the webinar recording later and other postings on the EZIZ webpage of webinars on EZIZ. If you'd like to be added to the CDPH email messaging listserv for California immunization providers, please email your request to Blanca Corona at blanca.corona@cdph.ca.gov. And if you have post-webinar related questions, you can email Rebecca Boyte. That's Rebecca with one C, REBECA.BOYTE@cdph.ca.gov. Next slide. We've got some objectives today, and by the end of the webinar, we would love for you attendees to be able to explain current disease rates of vaccine-preventable diseases that can impact pregnant persons and their babies, implement evidence-based strategies to boost prenatal vaccination rates, and identify resources to improve your individual vaccination practice, for example, billing and coding, free patient materials, and more. Next slide. And to provide today's information, we have the latest on rising vaccine-preventable disease rates with Dr. Floria Chi, strategies and tips to increase maternal vaccination and vaccination uptake with Dr. Neil Silverman, and many resources coming your way with Rebecca Boyte. We'll round things out with some Q&A, and we'll move on to our next slide. And as I do this, I want to welcome Dr. Floria Chi, who is a public health medical officer with the CDPH Immunization Branch. Dr. Chi brings 8 years of experience at the San Francisco Department of Public Health, including her family practice residency. Then as a medical director of Health Right 360's Women's Community Clinic. Most recently, she was part of the Pediatric Quality Improvement Lead at Maxine Hall Health Center. Dr. Chi received her MD and MPH degrees from Columbia University. So welcome, Dr. Chi, and go right ahead with your update.
Thank you, Leslie, for the introduction. I'll be giving a brief overview on rates of the vaccine-preventable diseases we're most interested in for prenatal immunization. Next slide. So this is from our most recent CDPH respiratory virus report, which is updated weekly, containing California COVID-19, influenza, RSV, and other respiratory virus surveillance metrics, such as those listed here, including test positivity, percent of admissions, deaths, total season pediatric deaths, and wastewater concentrations. The main takeaways are listed in the key messages below, which we'll go into a little bit in more detail, but the main key messages are that RSV and flu activity are low but increasing. COVID-19 is currently low in California. Also that only 9.6% of Californians have received an updated COVID-19 vaccine, and data reported through our California Immunization Registry or CARE show that many Californians still haven't received their flu vaccine. Next slide. Taking a closer look at COVID-19 test positivity, or percentage of specimens tested positive, we have this graph showing current levels in blue compared to the last 2 seasons, which are in green and brown. The red arrow points to where we are now, a test positivity of 2.2%, which is low, but we do anticipate it to increase as we enter the winter months. Next slide. Now looking at test positivity for flu, the current season is in light blue again, compared to our last 4 seasons. And the red arrow points to our current level, which is 7.5%. And it has definitely been increasing over the last month, as you can see. Next slide. Lastly, for RSV test positivity, the current season in light blue compared to our last 4 seasons, the red arrow shows that RSV test positivity is also increasing. Next slide. CDPH also tracks pertussis in a separate report, which is linked here. What we are seeing is that pertussis is returning to pre-pandemic levels. You can see on this graph showing California pertussis case counts over the last 5 years. On the left, you see what pertussis levels were pre-pandemic, and as you move to the middle, that it decreased significantly during the pandemic, but over on the right, pertussis levels have been increasing. Before the pandemic, pertussis was a public health priority, with infants dying from pertussis in California nearly every year. The last infant pertussis death in California before the pandemic was in 2019. Delays in routine vaccination during the pandemic have led to decreased population immunity, leaving many susceptible, and we have been seeing numerous clusters across the state. Sadly, we've already had 1 infant death in California this year. So we want to remind prenatal providers, infants too young for vaccination are at greatest risk for life-threatening cases. It's paramount to immunize pregnant persons to prevent infant hospitalizations and deaths. And compared to other immunization strategies, prenatal immunization has been shown to be the most important tool for preventing pertussis morbidity and mortality. So that's it for me. I want to thank you all for the work you do, and I'll hand it back to Leslie.
Thank you very much, Floria. Dr. Chi is available if you have questions. Please find that Q&A icon located on your screen. And in the meantime, I would like to introduce our next presenter, Dr. Neil Silverman. Dr. Silverman is a faculty appointee as Professor of Clinical Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA, where he also serves as the director of the Maternal Fetal Medicine Fellowship Program. In addition to his clinical and teaching responsibilities, he is the director of the department's New Infections in Pregnancy program. He's authored over 70 peer-reviewed manuscripts, 20 textbook chapters, and lectured widely with particular interest in obstetric infectious diseases, recurrent pregnancy loss, and thrombophilus, as well as prenatal diagnosis. Nationally, Dr. Silverman has served a 5-year term on ACOG's Practice Bulletin Committee for Obstetrics, serving as committee chair from 2011 through 13. He's also served on the Publications Committee for the Society for Maternal Fetal Medicine, SMFM. He is currently a member of ACOG's expert work group on immunization, infectious disease, and public health preparedness, and serves as ACOG liaison to the Advisory Council of the California Immunization Coalition. He is also a member of SMFM's new Committee on Infectious Diseases and Emerging Threats. Welcome, Dr. Silverman, and please proceed with your important updates on strategies and tips to increase maternal vaccination and vaccination uptake.
Thank you very much, Leslie. So, good afternoon, everybody. I have put together what I hope is a very practical approach to the topic for all of us who care for patients, and both the pregnant patients and their newborns. And next slide, if I can. Next. Just as a brief review, I wanted to go over vaccine importance strategies in the populations that we work with. Historically, it has been children that have benefited really the most from vaccines in terms of declines in disability and death. And that's been historically, again, because vaccination programs have been generally targeted to children. Every year, however, over 50,000 adults in the United States die from vaccine-preventable illnesses, largely from influenza and its complications. And this bit of information is before the pandemic. Vaccine-preventable diseases are significantly more common on an absolute level in adults than they are in children. We also have had reported that over half of the cases of significant vaccine-preventable illnesses reported to the CDC every year are in individuals over the age of 15. Now, many of the vulnerable adults at risk for vaccine-preventable illnesses are actually the ones that we see in our daily work providing healthcare to women. Traditionally, immunization services have not historically been part of obstetric or gynecologic care, and I'd like us to rethink that concept, and many of us already have incorporated it, but it is very important to address the benefit of vaccination, both for women and for pregnant women and the long-term health of their children. Next. Currently, we have 3 and now a 4th recommended and licensed vaccine for pregnant patients in the United States. Up until last season, we were all working with influenza, Tdap, and COVID vaccination in this population. And now, next, we are working in trying to vaccinate our pregnant patients against RSV for newborn protection. Next. So what I'd like to go through briefly are some talking points and effectiveness data that I think can help many of us who may encounter vaccine hesitancy in our daily practice when we're working with pregnant patients, and to emphasize the importance and public health impact of offering and administering vaccines to this particular population. Next. Starting with influenza, because historically we know more about the detrimental impact of influenza in pregnant populations, especially as it compares to non-pregnant women of comparable ages. And these data go back to the Spanish flu pandemic of 1917 and 1918, but pregnant patients have repeatedly been shown to be disproportionately affected by severe disease in influenza pandemics. And data have shown us that in every trimester of pregnancy, there are higher illness and hospitalization rates for pregnant individuals compared to those who are not pregnant. Even in pregnant patients who have no comorbidities or coexisting medical complications, they are anywhere from twice as high to become more ill in the first trimester to 5 times as high in the third trimester. And with comorbidities, that risk increase goes from 3-fold in the first trimester to 8-fold in the third trimester. Influenza vaccination during pregnancy has had a demonstrated benefit both for mothers and for their newborns. As a caveat, of all the vaccines that are available, and there are many, and they can be confusing as you look at the lists available, and we'll get to that, but the one that should not be given in pregnancy is the live attenuated nasal flu vaccine. And immunization with the season current inactivated flu vaccine is recommended for all pregnant women across all trimesters. Next. The neonatal benefits of vaccinating pregnant patients has been demonstrated. 1, the flu vaccine can't be given to children who are younger than 6 months of age. 2nd, pregnant patients have clearly been shown to develop protective levels of anti-influenza antibodies that can be transferred to their newborns after they are vaccinated. And 3rd, in 2008, there was a large randomized study of flu vaccine during pregnancy to show whether it had a newborn impact. And this was the first study to demonstrate that there was a 2/3 lower risk of laboratory confirmed neonatal influenza, not just general influenza-like illness, but laboratory confirmed illness in children whose moms had been vaccinated, and that protection lasted up to 6 months of age of the newborn. So these, I think, are really important talking points for those of us who work with pregnant patients who may be hesitant to be vaccinated against influenza, that there are large data sets demonstrating the effectiveness of this vaccine, both for maternal and newborn protection, and the safety of this vaccine when administered during pregnancy. Next slide. The newest slide that we are working with now is the one that was just introduced last year against RSV. RSV is the leading cause of hospitalization in the United States for infants. This is a vaccine that our pediatricians were extraordinarily excited to finally have available. Most infants are infected who become ill in the first year of life, and the vast majority of severe illness occurs within the first 2 years after birth. Almost 3% of young infants will ultimately need to be hospitalized for RSV illness in the absence of some type of immunization, either maternal or neonatal. And the highest RSV hospitalization rates occur within the first 2 months of life, with that risk declining as the infants get older. 80% of children hospitalized with RSV under the age of 2 had no underlying medical conditions. So these are otherwise healthy young infants who acquire RSV infection and have very severe disease because it attacks these very, very small developing bronchioles in the lungs that fill up with fluid. And these are the younger kids in early stages of newborn pulmonary development that wind up needing to be hospitalized. Next. Every year in the United States, in children under the age of 5, up to 300 deaths occur, but that, as you can see, is really just the tip of the iceberg. As the severity decreases, the impact from an absolute level on public health usage, utilization, and cost goes up to 80,000 hospitalizations a year, over 500,000 ER visits, and 1.5 million outpatient visits in RSV season related to RSV illness alone. Next. This is just a quick summary slide of the effectiveness data that has been shown related to this RSV vaccine that is now available for administration during pregnancy. So in its primary intent was to lower the risk of severe infection. So that primary outcome was severe lower respiratory tract disease. And within the first 3 months of life, this vaccine had an 82% decrease in severe infection in infants whose mothers had been vaccinated during pregnancy. And while the number decreased, the effectiveness was still in the 70% range in the first 6 months after birth. This is a very effective vaccine to prevent severe illness. For any illness, the overall effectiveness rates are about 50 to 60%, lower effectiveness for more mild illness, but where the impact really counts in severe disease, this has been shown to be a very effective vaccine. Next. And then just one additional reminder that COVID is still out there. And we had very recent data that were published by the CDC in the MMWR in September that showed that for the past 2 years, from October 22 to April 24, when they looked at all infants across the country that were under the age of 6 months who were hospitalized with COVID-19 infection, up to and over 90% of those infants stratified by age group were born to mothers who had not been vaccinated. and of the smaller subset of infants who died of neonatal COVID infection, all of those infants had unvaccinated mothers. So this is still a vaccination that needs to be discussed along with the others during prenatal care, because COVID, like influenza, can impact health for both the mother and the newborn and has effectiveness against preventing severe illness in both. Next slide. So what sort of vaccine barriers and results of our vaccination efforts have we identified? Next slide. For example, why aren't more pregnant women vaccinated against influenza? This is something we battle every year. We think that there's plenty of information out there, but when we do surveys after influenza season, folks still say that they didn't get adequate information, and that's where it becomes important to give patients information, one, in languages that they can understand fluently, not just that they are partially fluent in. And the CDC and the Public Health Department here in California publish patient information flyers in dozens of different languages to be available for hopefully almost all of our patients. There's also variability in the severity of any flu strain from year to year, and we know that there is a bit of a short memory syndrome. If people didn't see a whole lot of their friends or family ill with influenza despite not being vaccinated one season, it doesn't always provide a reminder for them that the next season is completely different with a different strain. There are still concerns over risk for vaccination during pregnancy. In addition, sometimes the barrier is on our end. There are concerns over vaccine reimbursement and litigation risks among providers. And over the years, although not recently, because the recommendations have been consistent for at least the past 12 to 15 years about when pregnant people can be vaccinated, there has been confusion, but now it's really across all trimesters. Next. To emphasize that influenza is still an issue, Dr. Chi alluded to this, but this is the most recent influenza illness map published by the CDC across the United States. And until a couple of weeks ago, this was all light or dark green and minimal cases reported. But you can see even here in California, early in the influenza season for the West Coast, we are seeing a moderate number of cases. And we are now at a time of year when patients are going to be traveling to see family. So I think it's important to keep a map like this at the back of our minds. So if patients are traveling to visit family in the Southwest or the Southeast in particular, they need to know that they are traveling to higher prevalence areas for influenza infections. And that's more of a reason for them to be considering being vaccinated to protect themselves as well as to protect older family members who may be at risk, whom they're going to visit. Next. Unfortunately, despite our efforts, when we look at flu vaccination rates among pregnant people from the beginning of the pandemic onward, about 50% of pregnant patients around the onset of the pandemic had been vaccinated against the flu. And you can see now that as of 2023 to 2024 last season, that had decreased to about 36%. Next slide. And for the current year, and this is a little slow, but this is just 2024, the current season. And this takes us till the end of November here. And you can see we still have just under 40% of individuals who have been vaccinated against influenza so far. So we still have work to do. Next slide. When we look at COVID vaccination, both intent and actual vaccination, the black part of these bars for the current season, respiratory illness season from September till a couple of weeks ago, tells us that only about 15% of individuals, this is adults and children, have been vaccinated with the newly updated COVID vaccine in the United States. So some of those numbers about kids becoming severely ill with COVID infection may repeat themselves as we look at the data at the end of this season. Next. The RSV vaccine, these are the vaccination rates from last season, which was the first season that the vaccine was available. We had some barriers because the vaccine was approved very close to the beginning of respiratory illness season. So we really had to do some legwork to get vaccines in our offices, in our clinics, and to get them in people's arms. Overall, the overall rate for the United States was this blue line. About 18% of pregnant people who were eligible for the vaccine were vaccinated. Very disappointing number. And even when you look across racial ethnic groups, the group that had the highest rates of vaccination, Asian population, was still only about 25%. Next slide. For this season, we are doing a little bit better, but we are starting to plateau. This is pregnant people being vaccinated for the current season from September through the end of November. And you can see right now we are at least about 36% across the United States. And we'll talk about things that we can do to potentially increase our rates of vaccination in general a little bit later. Next slide. And then Tdap, Dr. Chi alluded to this as well. We traditionally have done better getting people vaccinated against Tdap, but still the most recent year that we had complete data was between 2021 and 22, when we were in the mid to upper 70% range. And more recently, the CDC's reported that about 60% of women received Tdap during pregnancy in the last season. So we still have work to do. All right, next slide. So I'm trying to give you these background data, not to depress anybody, but just to know that we can't rest on any kind of laurels. We still have to understand how we can explain to patients that the vaccines are important for them, for their kids, for their entire families, and also to help our providers understand how best to get shots in people's arms, and also to be reimbursed for the outlay of the expense of the vaccines and the work that they do in counseling people. And as I've talked to many providers in the area, I think that the information about reimbursement and submitting claims is not as well understood as it could be. And we all know that the system is unnecessarily complex. And I'd like to provide you with some data for the remainder of this part of the webinar to help you understand and improve what you can do in your offices. All right, next slide. So one thing that we know is that immunization rates will increase both with access to the vaccines and the examples that we as providers set. Early studies, including one that we did over 20 years ago, and which was one of the first to look at this particular issue, is we looked at physician practices and physician philosophies in terms of how patients perceived what they had been told as demonstrated by how many of them had been vaccinated. So that if physicians were aware of the current guidelines regarding vaccines in pregnancy related to the flu vaccine, then patients in their practices were 3 times more likely to have been vaccinated. If the vaccinations were given in their offices, they were 20% more likely to have gotten the vaccine. And if the doctors said that they had received the vaccines themselves, well, that doubled the rate of likelihood of patients being vaccinated against the flu themselves at their visits. When we look at the RSV vaccine, there was a recent study that was presented at one of our infectious disease meetings this past summer that came out of UCSF that showed that they actually had a 70% acceptance rate for vaccinating their pregnant patients against RSV. And that was because all of their patients had the vaccine available to them in all of their outpatient areas and could receive it at the same time they were seeing their provider. I will tell you that we have similar data at UCLA. We have RSV vaccines and all of these vaccines available to be given to patients at the time they are seeing their providers. And our RSV vaccination rates were comparable to the ones at UCSF in the low 70s. So one is you have to have the vaccines available where people are. That other studies have shown that once someone leaves your office and has the nearest pharmacy information in their hand, they will be 30 to 40% less likely to get vaccinated than if it had been available to them in your office. Next slide. It's also important to know that the majority of the health plans that are currently available to patients across the country, ACA compliant marketplace health plans, have to cover preventive services without charging copayment or coinsurance. And this is true even if patients haven't met their yearly deductible. This is from the HHS website. But these services are free only when delivered by a doctor or other provider in the patient's network. And you can see that immunizations for adults is a huge component of this. These are the vaccines that are covered under this guideline. And when you look at specialized adult populations, like adults over the age of 60 or 65, other vaccines fall into this, like pneumococcal vaccines and shingles vaccines. Next slide. We also need to address the fact that as we add more vaccines to the recommended schedule for pregnancy, there is an increasing complexity for this maternal immunization schedule in comparable windows. So except for Tdap, right now the focus is getting influenza, COVID, and RSV vaccines into pregnant patients during a respiratory illness season. Tdap is given year-round, not just during the respiratory illness season, and that increases patients' concerns about getting potentially more than one vaccine at a single visit. We know that the majority of these vaccines can be given safely, concomitantly, and especially two vaccines, for example, Tdap and influenza. There are data on those being given concomitantly, COVID with the others, and RSV given in conjunction with other vaccines. There are more data emerging since last season that show no increased risk of significant side effects. Next slide. Next slide. So the other thing I would just like to finish up with is talking about how we bill for immunizations. So as most of you know, submitting a claim for any sort of patient care encounter involves providing a procedure code, or the CPT code, as well as a diagnosis code. And if these are not, if both of these are not provided, or if the codes don't match the service provided, it does increase the risk that the claim will be denied. So for CPT codes, there is a general and we'll get into this, and I have a resource for you so you don't have to memorize these. But for example, a generic immunization administration procedure code exists. And then for each specific vaccine, there is a different CPT code for that vaccine. The diagnosis code, there are generic diagnosis codes, so it's a Z code as an encounter for immunization, but some of these vaccines even have more specific immunization codes that we aren't always aware of, which is why I wanted to be able to provide this information to you so that you and your offices and your staff can know where it lives. Next slide. Just as an example, this is a list of all of the influenza vaccines that are available for use for the current influenza season in the United States. And you can see that there are many, and each one of these specific vaccines has its own CPT code. So that if you are providing, for example, this particular vaccine in your office, and I'm not pointing any, but you submit a code for one produced by another manufacturer, it may not be accepted. So that's why, unfortunately, we need to know how to play the game properly and be able to submit the codes that are concordant with what we are giving. This is not, I don't obviously support this game, but it exists. And I would like us to all have the tools to be able to do this efficiently. Next slide. I think one of the best slides, the best resources here has been published by ACOG and updated. There's a link at the bottom here, but there is an immunization coding for OBGYNs document that exists on the ACOG website that specifically addresses immunization coding for OBGYNs. And next slide. So the ICD-10 diagnosis codes are found in this document, and diagnosis codes are used for vaccinations and categorized this way. So there are folks who are being vaccinated post-exposure. There are vaccine diagnosis codes for recommended vaccinations, including prophylaxis. And then there's also a code for which a planned immunization was not carried out. All of these are valid, accepted codes that can be used based on based on how the encounter fits into a description. Next slide. Here, for example, you can see that these are an example of Z codes, diagnosis codes for exposure to a variety, and you can see they vary. So you have to be able to know which fits your patient. There's one that's generic. So if someone is exposed to a viral communicable disease, that's different than giving them a vaccine for an exposure to rabies, for example, and the codes differ. Next. And then the current procedural, these are the procedure codes. There are codes for individuals who are 18 years of younger. So if you have adolescent patients whom you manage in your practice as well, giving them a vaccine is great, but it's not the same code as you use for someone who is defined as an adult 18 years or older. And if you give two vaccines simultaneously, you cannot submit the same procedure code twice, but there is a separate procedure code for each additional vaccine that you might administer at the same visit. So this is all in that document. And then I'm just going to finish up here, and we'll answer any questions. Last slide. And this is an example of the CPT codes for administration, not just of a vaccine, but of a specific vaccine. And You can see these, for example, are hepatitis vaccines for kids or for adults. And any of you who deal with Medicare patients, there is a completely separate list of Medicare administration codes for certain vaccines that are given to older or disabled populations who qualify for Medicare. And these are G codes, not the 904-based codes. So this is all happily in the Medicare. In the ACOG document, I would advise you to find it, print it out, circulate it, post it in your offices, and vaccinate and get reimbursed and make us all healthier. So I'm going to leave you with those sentiments, and thank you very much for your attention.
Well, thank you so much, Dr. Silverman. We certainly appreciate the realistic viewpoint that you provided and this important information on the coding. We're going to go ahead and move on in our presentations, but we'll loop back for questions. And again, Q&A is available if you would like to ask. But in the meantime, we're jumping to some very valuable resources. And to bring you those, we invite Rebecca Boyd to share. Rebecca?
Thank you, Leslie. Next slide, please. I first want to start out with a shout out to the California Immunization Coalition. We've been collaborating on this great project called shotbyshot.org. There was a question submitted during the registration process that asked, what videos can I share with pregnant patients? And these are wonderful stories because they really put a face to the vaccine-preventable disease. And they remind us that they're out there, but we have the tools to protect ourselves. The first story I wanted to highlight is London's pertussis story of a woman, a mom, who didn't get vaccinated during pregnancy, and her baby nearly passed from pertussis, but luckily recovered. And the second story, unfortunately, the ending's not so happy. The mom lost her baby to RSV. Next slide, please. At CDPH, we also have numerous materials available. This brochure specifically has been around for a long time because it's been so welcomed by our providers. You can order free copies using the link provided in the slides. They're available in English and Spanish. And oftentimes our providers like to introduce them as part of the pregnancy packets so that it becomes easier to speak about vaccinations down the road. It talks about vaccines recommended before, during, and after pregnancy. Next slide, please. This is another wonderful material for our pregnant patients. And this just goes into greater detail about what to expect for the vaccines, how effective they are, where to get immunized. Are they really safe? Are they really needed, right? So all the information is covered in this material. And it also provides a prescription because, as Dr. Silverman explained, there are numerous vaccines that are recommended during pregnancy. Some you may offer and some you may not, and you may have to refer out. And this just provides some information to the pregnant patient and the pharmacist as to what's really being recommended and what she or he or they should receive. Thank you. Next slide. Another question that came in through the chat was what culturally sensitive materials are available, or are there any materials available for Black patients? And this is a beautiful campaign produced by CDC, From Me to You. It was informed by Black pregnant patients about, well, it's maybe designed centrally around the beauty, the excitement, and the cultural legacy of Black parenthood. So I invite you all to go and check that out. Next slide, please. We also have some social media campaigns, some by Health and Human Services, like you're eating for two, sleeping for two, and you're also protecting for two. And then on the right, our CDPH pregnancy toolkit with additional materials. Next slide, please. CDC also offers some great resources for providers. On the left is just a quick sheet with information about routinely recommended vaccines during pregnancy, with the caveat that the COVID vaccine should be 2024, 2025 on the left. And on the right is comparison between infant and maternal RSV immunizations and some clinical considerations for you to take into, for you to consider. Next slide, please. There are also some gestational wheels available through our genetic disease screening program. I encourage you all to order those. And on the right, we have a prenatal vaccination declination form that you can utilize to document any declinations to vaccines in your patient charts. Next slide, please. We also got a request over the registration about written communications. This is a sample robocall message or a patient portal message you can send out when patients are due for RSV vaccine. So whether you stock or not, I recommend that you take a look at this and send it out to all your patients due for RSV vaccine. Next slide. And we also offer great COVID vaccine resources, including this timing guide and this product guide. Next slide, please. And to wrap it up, there were just so many resources to cover. I didn't have the time, but I wanted to make sure you have those links available. On the left, it's a link to our EZSC flu materials, and on the right, we have this great infographic that we often use during presentations to explain the importance of maternal transfer of antibodies after vaccination. We have a link to the prenatal toolkit, our maternal infant health assessment data specific to California, RSV resources, FAQs, and COVID-19 resources as well. And that's it for me. Thank you so much, Leslie. Back to you.
Thank you, Rebecca. My goodness. I just want to move to our next slide. And as I do that, I just saw a little heart come up, but I was going to ask you guys very informally, how many of you learned something new today during today's session or accessed a new resource that you're going to be able to share and find helpful for the work that you do? Yeah, just give the emoji of your choice, but really glad to have you join us today. I've gotten so much from Dr. Chi, Dr. Silverman, and Rebecca today. So thank you all to the presenters for preparing these slides and going through this with us. It seems like it was pretty thorough, and we don't have any current questions other than people want this slide deck. So Billy Dawn has added that link to the chat, and you can find it again. I put it in Q&A, but I do want to loop back and just check in just to reaffirm a couple questions that came in earlier. And this is Dr. Chi, when we're looking at RSV, can you give just another example of how RSV is impacting mothers and babies during this winter season?
Sure. So as I showed in one of our slides, we are seeing increases not only in RSV activity, but also in infant hospitalizations, ED visits nationally this season. I don't know if we have time, but in the appendix, there is a slide that shows that RSV accounted for nearly 80% of all infant respiratory virus hospitalizations last season. And this season, I just checked the graph. It is looking to be very high as well, maybe in the 90%. We have data from CDC that shows that children 0 to 4 years with RSV are accounting for 12% of emergency department visits. That's all ED visits. So that's also pretty significant. So we do see that RSV is definitely affecting us and anticipate it to continue to affect us. We talk about it mostly in babies and older adults because they're at most risk for severe disease. And for moms, it's important to get them vaccinated to pass that protection to the infant. Hope that helps.
And we are going to move through. We do want to highlight, we have information. Dr. Chi, is this the slide you were referring to in the appendix?
Yes, yeah, this slide goes over the hospitalizations. It doesn't show our current data very much. You can see it kind of cuts off at September, but if you go to the link on the slide, and I can provide the link in the chat as well, you can see the most recent data for this season, which is showing that RSV is a large proportion of hospitalizations for infants.
Thank you for that. And it is already in the chat. We'll make sure that you guys can access that link. Thank you for that. And we do have an appendix right at the end with just a few slides if you are interested. Information. We'll go back maybe, Charles, to the appendix section here. Just want to highlight that we have on the next slide, Tdap coverage estimates in California. On the next slide, there is information on the COVID-19 hospitalizations, and that next slide we just showed to you that Dr. Chi mentioned on RSV. So Dr. Chi, anything else you want to say about the appendix slides?
No, it just provides some extra information about COVID-19 and some data on coverage, vaccine coverage in California.
Thank you. And Paula, thanks for your question. There's a comment here. I'd love for our panelists to consider maybe some practical application and support. Paula shares our county had a few calls from child care centers wishing to learn more about how to work with the fear families have about RSV, flu, and COVID immunizations, despite the education they've been provided. So in your practical experience or suggestions, panelists, how do you support families that may come to you with this concern or fear about immunization?
I can't really talk about child care centers, but I can talk about the questions that I get on a pretty regular basis from folks who are being managed during their pregnancy. And the flu vaccine is the same flu vaccine that people have been given for quite some time. Its effectiveness is pretty well proven. We don't all the match is not always perfect, but from a safety point of view, the safety of the flu vaccine and Tdap, for example, have not changed. RSV is a relatively new vaccine in our toolkit, but I also explained to them that although I don't necessarily think that the COVID vaccine using a newer technology makes it less safe than any of our other vaccines that are used, the RSV vaccine is based on a very traditional vaccine platform. So it's a recombinant protein vaccine platform, similar to, actually identical to the vaccine platform that's used for vaccines against hepatitis B and meningococcal infections. So there's no reason to think that the RSV vaccine still has not, but in the future will have any additional safety markers that emerge for adults or exposed children, because it is basically the same as the Hep B vaccine. It's just a different protein that's been plugged into the vaccine itself. COVID vaccines, I try to respectfully address patients' concerns. I tell them that I've gotten more vaccines than they can imagine, and I am not tentative about getting them. There is a protein-based vaccine against COVID that is also available, and I tell them that that is an option for them as well if they are uncomfortable still about a newer technology vaccine like the mRNA vaccines, that there is the Novavax vaccine is based on a traditional protein platform. So I try to I will always try to hear their concerns and try to address what they are expressing. I think that I want this to be an open discussion between both sides. And, all we as providers can do is to do our best to give patients information that they are equipped to understand and hope they make a decision to help their family's health.
Thank you for that, Dr. Silverman. And I think that last sentiment, in addition to all that good information, that opportunity to really listen and make it a conversation where the provider is listening to the concerns goes such a long way. We've heard time and time again from many of our presenters. So thank you for reinforcing that the conversation, keeping the options open, and um, empathy goes a long way with folks who are concerned. And again, I appreciate Dr. Silverman, your very realistic view of what the numbers are, and Dr. Cheese, and just continuing to provide support to the patient. So Paula, thank you for opening up that comment and question to the group. We've also dropped into the chat. The EZIZ page from CDPH offers a resource on vaccine safety with a section for parents. So we want to ensure that you have access to that. That is a because you showed up freebie based on Paula's question. We don't have that in the slide deck, so you might want to snatch that one up and click on that link to access that page. And as we begin to wrap things up, I just want to pause, and we're going to go ahead and move to our thank you slide. But as I do that here, we want to highlight the websites to learn more. You can find the CDPH immunization branch link on the right, the American College of Obstetricians and Gynecologists website link, and then California Immunization Coalition. Learn more about this fantastic group, CIC, about us. You can click on the links. We also wanted to thank Drs. Neil Silverman and Haley Miller behind the scenes from ACOG, Dr. Floria Chi, Public Health Medical Officer, and Rebecca Boyd from CDPH. And again, our gratitude to CIC's Cameron Lawton and Catherine Flores for their webinar support, and Billy Don Greenblatt and Charles Roberts from CDPH. Panelists, any final thoughts as we wrap things up today? Just going to give you the last word. If you'd like it, you're welcome to share any closing words to our attendees today.
Dr. Chi, anything you'd like to say?
No, just thanks everyone, and lots of appreciation for this collaboration and all the work that everyone is doing. I know that it's busy and not always easy.
Yeah, I'd like to reinforce that as someone who sees patients almost on a daily basis and confronts the same questions that you are. I really wanted to focus this not so much on all the intricacies of the vaccines, because that is what I think folks are used to hearing. I really think that the practicality of some major points to try to get across to patients about the effectiveness and importance of vaccination would be key. And I don't think, you know, even folks who are recently out of practice are awash in how to bill and do things so that they can get appropriately reimbursed for the work they do, even though it's still just a fraction of the time that they put into it. So that's why I wanted the billing and documentation part of this talk to be there. I'm around, and folks can certainly reach out for any additional questions if you have them. But I really wanted this, as we talked about it, to be a practical use, daily use kind of talk for everybody.
Thank you, Dr. Silverman. And again, thank you, Dr. Chi, Dr. Silverman, and Rebecca. And we will move to our final slide. And we want to thank all of you for attending today. We hope that you will share this out with other providers who can benefit from its use. And in the meantime, as we close things out, we wish you the happiest holidays. Please take care of yourselves during this season. And with that, we will conclude today's session. Thank you all.